Like and to subscribe and go answer the multiple choice questions under the community tab. They'll really kind of help all this information stick. So like I said, today we're going over the PDA. So there's going to be 4 parts to this video. First of all, we'll go over the anatomy and the physiology of a PDA. Then we'll go over the signs and symptoms of a PDA. Number 3, we'll go over the echo findings. And number 4, we'll finish with the treatment and management strategies for PDAs. So number 1, let's start with the anatomy and physiology. So as usual, I'm going to draw the little box heart so that you can understand it really well. So first of all, let's go over a normal heart. Actually, a normal heart in utero, really. So remember, we have 4 chambers in the heart. So the left atrium, left ventricle, right atrium. Remember, whenever we draw anything or whenever we look at x-rays in medicine, we're always assuming that we're looking at somebody. So imagine that you're looking at me, this is the left side of my heart, this is the right side. So left atrium, left ventricle, and then the left ventricle pumps to the body, so through the aorta, so this goes to the body. The right ventricle pumps blood to the lungs. And this is the pulmonary artery. These are my lungs. Okay, and then we have drainage coming back from the body and drainage coming back from the heart. So in a normal heart, the blood comes back from the body and the blood is going to be blue blood because the body has used all the oxygen. So the right atrium, the right ventricle pumps it to the lungs and the lungs give the blood oxygen. So now the blood is nice and bright red, so it comes back from the lungs into the left atrium, the left ventricle, and then the aorta pumps that blood out to the body. So you can see in a normal heart, the right and the left sides of the heart are completely separated. The right side is responsible for sending the blue blood to the lungs, and the left side is responsible for sending the nice red oxygenated blood to the body. Now let's talk about what happens in utero. So remember, in utero, the lungs are not being used. The lungs, as we've talked about over and over again, are filled with fluid in utero. They are not providing oxygen or any means for gas exchange for the baby. So in utero, the placenta does that job. The placenta is the one that gives the oxygen and gets rid of the carbon dioxide. So in utero, when the blood is coming back from the body, we don't really need it to go to the lungs. We need as much of it to be shunted towards the left side, towards the body, so that that blood could go to the placenta and get oxygenated. So in utero, there is a vessel between the pulmonary artery and the aorta called the Ductus Arteriosis. The Ductus Arteriosis, which provides a shortcut for that blood coming back from the right side of the heart to go to the body. There's actually another little shortcut here as well, and that is called the PFO, or the patent foramen ovale. But for the purposes of this, we're going to be talking about the ductus. So, as you can see, to reiterate, the ductus is between the pulmonary artery as well as the aorta. And it's just a shortcut for blood coming back from the body, going to the right ventricle. Because we don't really need that blood going to the lungs, it can now take a shortcut. Remember that blood flows in the heart dependent on the pressures that it sees. If the blood sees a higher pressure, it's going to take the path of least resistance. And because in utero the lungs are filled with fluid, there's a very high pressure in the lungs. So that blood is going to come out of the right ventricle, see that high pressure and be like, nope, I'm going to go this way through the ductus into the body. So for what it's worth, in utero, there's actually a right to left shunt through the ductus. So normally what happens after a full-term baby is born is that the ductus is exposed to a lot of oxygen, doesn't have all the placental factors circulating around anymore, so it doesn't have any of the stimulation to stay open, and that ductus slowly closes. So that's what happens normally in a term baby. However, in a preemie baby, the ductus doesn't get all the signals that it needs to close. So very often in a preemie baby, that ductus, which again is the shortcut between the pulmonary artery and the aorta, will stay open. So immediately after birth, this isn't a huge issue because the pressure in the lungs is still on the higher side, and so there probably isn't going to be a lot of shunting either way between the pulmonary artery and the aorta. However, over the next few days of life, maybe a week or so, what ends up happening is the pressure in the lungs, the water is already left, the lungs relax a lot more, the pressure in the lungs falls and falls and falls, and the pressure in the body, if anything, gets higher and higher. So now what's going to happen is if that ductus is still open, the blood, which normally is coming back from the lungs, which is now bright red blood, normally it comes out from the aorta. Now that blood is seeing this low pressure system on the right side, and so exactly like we said already, blood is going to go to the areas of the lowest pressure. Like all fluids, it's going to flow to the path of least resistance. So this nice bright red blood that's coming out of the aorta sees this open ductus and then shunts over to the lungs. So this is a left to right shunt through a patent ductus arteriosis. Obviously, we're still going to have some blood going to the body, but a part of that blood is going to be shunted from left to right through the ductus. So why do we call it a PDA? Because that ductus is patent. As you know, patent means still open. So patent ductus arteriosis results in left to right shunting when the pressures in the lungs have fallen. When the pressures in the lungs have fallen. Okay, I want to make a pretty important point here that is very clinically applicable. Remember, if you watch the whole pulmonary hypertension video, that we have an artery coming off there, which is preductal, as well as two arteries coming off there, which are postductal. This artery actually ends up giving the blood to the right arm, as well as the right side of the face. If you notice here, the blood is being shunted left to right, so it's all red blood. So with a PDA, you are not going to have any pre- and post-ductal saturation difference because it's oxygenated before the ductus and it's oxygenated after the ductus because all the shunting is left to right. So you cannot get a pulse ox on your right hand and on your foot, see a difference and say, oh, that must be a PDA with left to right shunting, because with left to right shunting, all the red blood is just going towards the lungs. A lot of people get confused about that, so I just really wanted to clear that up. Let's talk about the different sets of signs and symptoms. So let's start with the lungs. Like we said, there is too much blood now going towards the lungs. So the lungs, as you know, are kind of like this spongy material. And as you can imagine, the more wet they get, the harder it is to open up and the less good they are at exchanging gases. So if you do have a bad PDA, then those lungs will be wetter, probably stiffer, and you'll probably need a higher support to just get the gas exchange that you need. So you might see that the FiO2 has gone up, you might be needing a higher PEEP, you might be needing a higher tidal volume, just to get the same amount of gas exchange that you were getting before you had all that left to right shunting. So the second set of symptoms that you would expect to see is from not enough blood going to the body or decreased perfusion to the body, because a lot of that blood, as we keep saying, is being shunted to the lungs. So remember, when the body is not getting enough oxygen, then what it's going to do is try to kind of shunt blood away from less necessary organs. So obviously we need to make sure that we're still getting enough blood going to the brain. You need the brain every single second of your life. But your kidneys and your gut, for example, are less necessary for survival on a second-by-second basis. So if you do have decreased perfusion to the body, then one of the earliest signs that you'll see is less blood going to the kidneys and less blood going to the gut. So what would we actually see on the baby? Well, with the kidneys, with decreased perfusion, you would see a lower urine output, and you would see, if you're ordering labs, the creatinine creeping up, which would be a sign that the kidneys weren't getting enough blood. As as opposed to the blood going to the gut, what you could end up seeing is that the baby is just not tolerating feeds as well. So what would that mean? Maybe they would have more residuals. Maybe they're stooling less because the peristalsis has gone slower. Maybe they've got slightly more abdominal distension. Worst case scenario, they might even have kind of green residuals or like really sickly appearing gut. So what you would expect from decreased perfusion to the body is, first of all, decreased perfusion to the kidneys, decreased urine output, increased creatinine, and decreased perfusion to the gut, which would manifest as increased residuals, decreased peristalsis, decreased stooling. Right, let's talk about the signs and symptoms you'd see on a baby. As you all know, one of the things that you're always listening for when you're examining a premature baby is for a murmur. So what is a murmur? A murmur is just when you hear unusual blood flow when you're listening to the heart. So normally you're hearing da-da, 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 and what that signifies is the valves closing between the atria and the ventricles, and the valves closing between the ventricles and the pulmonary artery and the aorta. So normally you're just hearing da-da, da-da, da-da. If you ever hear a sh or the ch or sh, then that's a sign that blood is flowing through an abnormal vessel, or it's going too quickly, or there's something wrong with the valves. So we always listen for a murmur when we're examining preemie babies. The murmur of a PDA is very pathognomonic. So you listen to it and it sounds so consistent with it being a PDA. And that's because it's pretty much continuous. And normally it's a very harsh sound. People describe it as a machinery-like sound. So make sure that you really go out of your way to try to listen to and identify the sound. But what you're basically hearing is like a dish, dish. It's really pansystolic, which means that all the way during systole, you can hear this really harsh murmur. And if you think about it, in babies, their heart is beating so quickly that really, sometimes all you can hear is the murmur. You're basically hearing shh, 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 like that, over and over again, as you're hearing the blood shoved through that ductus. Okay, the second big symptom that you would see, or the sign that you would see on a baby's physical exam, is bounding pulses. So if you remember from the widened pulse pressure video, what you can end up with in a PDA is a widened pulse pressure. And that is because you've got a lower diastolic pressure, because a lot of that blood has kind of been, shunted away into the lungs, whereas your systolic pressure might be even higher because there's so much more blood coming back from the lungs and the body into the left ventricle. So your cardiac output, if anything, might be a little bit higher. So with a widened pulse pressure, what you can very often feel is bounding pulses. So if you feel the femoral